Audio Lecture 1. Antepartum Fetal Testing, the Non-Stress Test, the Biophysical Profile, and the Modified Biophysical Profile. This lecture is based mainly on GABI, Chapter 11, Antepartum Fetal Evaluation, with reinforcement from GIB, Chapter 6, Antepartum Fetal Surveillance. Let us begin with the central idea. Antepartum fetal testing is not a crystal ball. It does not reliably predict every acute catastrophe, such as abruption, sudden cord accident, or abrupt maternal metabolic deterioration. What it does best is different. It asks whether the fetus still has the neurologic, cardiovascular, and placental reserve to behave like a healthy fetus. That sentence is the anchor for the whole topic. When a fetus is well oxygenated, the central nervous system is active. The autonomic nervous system communicates with the heart. Movements are accompanied by accelerations. Breathing movements appear. Tone is preserved. Amniotic fluid remains adequate because chronic uteroplacental function has allowed renal perfusion and urine production. So the tests are not random rituals. They are a structured bedside assessment of fetal behavior and fetal environment. Let us start with the non-stress test, or NST. The name matters. It is non-stress because we are not deliberately provoking contractions. We are observing the fetal heart rate in its ordinary condition, usually in an outpatient setting, while avoiding maternal supine hypotension and while tracking fetal movement and uterine activity. The physiologic foundation is simple and powerful. In late gestation, a healthy fetus has frequent heart rate accelerations. GABI notes an average of about 34 accelerations per hour. These accelerations require intact coupling between the fetal central nervous system and the fetal heart. Hypoxia disrupts that coupling. At term, fetal heart rate accelerations are associated with fetal movement more than 85% of the time, and more than 90% of gross movements are accompanied by accelerations. This is why an acceleration is reassuring. It is not just a bump on paper. It is a sign that the fetus can move, perceive or generate movement, and respond through intact autonomic control. Now the practical definition. After 30 to 32 weeks, the classic reactive NST requires at least 2 accelerations, each rising at least 15 beats per minute above baseline, and each lasting at least 15 seconds, within a 20-minute window. Before 30 to 32 weeks, the fetus is neurologically less mature, so the threshold is usually relaxed to 10 beats for 10 seconds. This distinction is clinically important. A 28-week fetus is not a failed-term fetus. It is a developing fetus with different autonomic maturity. Now let us add the concept that saves you from overreacting. The most common reason for a non-reactive NST is not acidemia. It is quiet fetal sleep. Patrick and colleagues, as summarized in GABI, found that the longest interval between accelerations in healthy term fetuses is usually about 40 minutes. But a fetus may go as long as 80 minutes without accelerations and still be normal. That is highly testable, but more importantly, it changes your clinical posture. A non-reactive tracing is not automatically a dying fetus. It is a question. Is this sleep, medication, immaturity, smoking, beta blocker effect, fetal anomaly, or hypoxia? GABI describes the practical response. If the first 20 minutes are non-reactive, extend the observation. Many non-reactive tests become reactive later the same day. If there is no reactivity after extended monitoring, then further evaluation is required, usually with a biophysical profile, or BPP, or a contraction stress test, or CST, depending on local practice. Vibroacoustic stimulation, or VAS, is a useful bridge. It tries to move the fetus from quiet sleep to active sleep. It can shorten testing time. A reactive NST after VAS appears to be as reassuring as spontaneous reactivity. But if the fetus remains non-reactive after stimulation and extended observation, the question becomes more serious. Let us pause and summarize the NST. A reactive NST is reassuring because accelerations reflect intact fetal neurologic and cardiovascular response. A non-reactive NST is common, especially earlier in gestation, and often reflects sleep. At term, absence of accelerations can persist up to 80 minutes in a normal fetus. The key is not to worship the first 20 minutes. The key is to interpret the tracing in gestational age, medications, fetal state, and clinical context. Pause here if you want to review NST logic before moving to the BPP. Now we transition to the biophysical profile, or BPT. The BPP is an in utero physical examination. It asks a deeper question than the NST alone. Is the fetus showing the behaviors that require intact central nervous system function? And is the environment consistent with adequate chronic placental function? Gabe emphasizes that the BPP combines 5 variables. The first is fetal breathing movement. The second is gross body movement. The third is fetal tone. The fourth is reactive fetal heart rate, essentially the NST component. The fifth is amniotic fluid volume. Each normal variable earns 2 points. Each abnormal variable earns 0. So the maximum score is 10, and the minimum is 0. Let us make each variable memorable by linking it to fetal neurophysiology. Fetal tone is one of the earliest fetal neurologic activities to develop, beginning very early in embryonic life. Because it is phylogenetically and developmentally primitive, it is often the last biophysical variable to disappear, with worsening hypoxia. Tone means active extension, followed by return to flexion, or opening and closing of a hand. It tells you the fetus has preserved fundamental motor control. Gross body movement is slightly more vulnerable. A normal BPP requires at least 3 discrete body or limb movements in 30 minutes. Continuous movement counts as 1 episode, not many. The reason is that we are evaluating organized episodes, not just twitching or artifact. Fetal breathing movement becomes regular around 20 to 21 weeks. A normal BPP score requires at least 1 episode lasting 30 seconds in a 30-minute observation. This is a favorite exam point. The fetus is not breathing air, but breathing movements train the respiratory apparatus and reflect central nervous system integrity. They are also state-dependent. A quiet fetus may not breathe during the observation window, and maternal glucose, smoking, narcotics, and corticosteroids can affect breathing movement. The NST component gives us the acute heart rate response. After 30 weeks, normal means at least 2 accelerations of 15 beats for 15 seconds, associated with fetal movement within 20 minutes. Finally, amniotic fluid volume is the chronic piece. In the BPP, normal fluid usually means at least 1 pocket, measuring at least 2 centimeters in 2 perpendicular planes. Why does fluid belong in a fetal well-being score? Because after mid-pregnancy, amniotic fluid is largely fetal urine. Chronic fetal hypoxemia redistributes blood flow away from the kidneys, reduces urine production, and can produce oligohydramnios. So fluid is not just water, it is a placental memory trace. Now let us translate the score into action. A score of 10 is normal. A score of 8 is also generally normal, assuming fluid is adequate. The usual response is repeat testing at weekly to twice-weekly intervals, depending on the indication. A score of 6 is equivocal. This is where many mistakes happen. A 6 does not always mean deliver immediately. If the pregnancy is at or beyond 36 to 37 weeks, delivery is often considered. If the fetus is preterm and pulmonary maturity is not established, repeating the BPP in 4 to 6 hours is often appropriate, unless oligohydramnios is present. Oligohydramnios changes the meaning because it suggests chronic compromise or membrane rupture, not just a transient sleep state. A score of 4 is concerning. Gabby's management table says that at 36 weeks or beyond, delivery is recommended. If the fetus is very preterm, particularly before 32 weeks, repeating the score may be considered because the cost of iatrogenic prematurity is high. But persistent severe abnormality is not ignored. A score of 0 to 2 strongly suggests chronic asphyxia. The observation time may be extended up to 120 minutes. But if the score remains 4 or less, delivery is recommended regardless of gestational age. That last phrase is dramatic because it captures the balance. At some point, remaining in utero is more dangerous than prematurity. The BPP has an elegant logic. The first functions to disappear with hypoxia are the more vulnerable, higher-order activities, especially fetal heart rate reactivity and breathing. Tone disappears late. Amniotic fluid reflects chronicity. So the BPP is not 5 equal trivia facts. It is a staged neurologic and placental examination. Now let us address predictive value. Gabby reports that a normal BPP has a very low false negative rate, less than 1 fetal death per 1,000 within 1 week of a normal profile. But abnormal or equivocal profiles can have substantial false positives, especially a score of 6. That is why clinical context matters. A fetus after corticosteroids may temporarily show reduced breathing movements and reduced heart rate reactivity. A fetus in quiet sleep may look less active. A premature fetus may not behave like a term fetus. This is also why the BPP was developed historically, to reduce the high false positive rate of the NST and CST by combining variables. One abnormal variable is noisy. Multiple abnormal variables together are more convincing. Pause here and hold the core model. NST is acute autonomic reactivity. BPP adds ultrasound behavior and fluid. Fluid is the chronic placental environment variable. Now let us move to the modified biophysical profile, or modified BPP. The modified BPP is built on a very practical insight. The full BPP takes time and ultrasound expertise, but the two most useful dimensions can be combined efficiently. The NST reflects the current fetal condition. The amniotic fluid volume reflects longer-term uteroplacental function. So the modified BPP combines the NST with a fluid assessment, often the deepest vertical pocket, or DVP. A DVP greater than 2 cm by 1 cm is usually considered reassuring in this context. Gabby cites large experience, showing that the modified BPP performs comparably to the full BPP, with a false negative rate of about 0.8 per 1,000, meaning fetal death within 1 week of a normal test. That is why it is attractive for large high-risk populations. It is quick, scalable, and clinically useful. If the NST is non-reactive despite vibroacoustic stimulation or extended monitoring, or if the fluid is abnormal, then further testing is needed. That further testing may be a full BPP or a CST. Now let us address DVP versus amniotic fluid index, or AFI. This point links antepartum testing to the amniotic fluid lecture. AFI sums the deepest pockets in 4 uterine quadrants. DVP measures the single deepest vertical pocket. The important clinical evidence is that AFI diagnoses more oligohydramnios, causes more induction, and increases iatrogenic prematurity, without improving perinatal outcomes compared with DVP. Therefore, many modern recommendations prefer DVP for diagnosing oligohydramnios in surveillance. The memory hook is this: AFI finds more low fluid, but finding more does not mean saving more. Sometimes it means intervening more. Before we close, let us place Doppler ultrasound in its proper lane. Doppler is powerful in suspected fetal growth restriction because it interrogates placental resistance and fetal adaptation. But Gabby emphasizes that Doppler is not a primary general screening test for all high-risk or low-risk pregnancies. Its strongest role is in suspected intrauterine growth restriction, where umbilical artery and other Doppler findings help time surveillance and delivery. Now, final synthesis. First, remember the physiology. Fetal accelerations require intact central nervous system and heart coupling. That is why the NST works. Second, remember fetal state. A non-reactive NST is often sleep, and a healthy fetus may lack accelerations for up to 80 minutes. Third, remember the BPP as a layered exam. Breathing, movement, tone, heart rate reactivity, and fluid are not random. They represent neurologic function plus chronic placental environment. Fourth, remember management. A BPP score of 4 at or beyond 36 weeks generally means deliver. A persistent score of 4 or less after extended testing is dangerous, even if preterm. Finally, remember fetal surveillance is layered and nuanced. Remember the modified BPP. NST plus fluid gives you present condition plus chronic context. And for fluid, deepest vertical pocket often prevents unnecessary intervention compared with AFI. End of Lecture 1. Pause here before continuing to amniotic fluid physiology and oligohydramnios.